And welcome to this special episode of the Pandemic Podcast, where we have a panel discussion about the issue of childhood vaccination. With the rollout of the second dose of the vaccines for children between ages 5 and 11 now likely to go ahead in Wales, it is expected that other parts of the UK will follow. Now, we've been repeatedly told that the COVID vaccines are safe and effective and that the benefits outweigh the risks. But how does this apply to children? Do they really need the vaccine? Has the changing nature of the virus of Omicron and what that's brought changed the picture? In this important panel discussion, we're going to ask a variety of questions to assess the underlying need to vaccinate children and some of the conversation around risk and benefit, and also discuss a way forward. And I'm delighted to be joined today by Dr. Ros Jones, Dr. Dave Cartland, and Dr. Roland, Salmon, all signatories of the Children's COVID Vaccine Advisory Group letter that's been published this week. Dr. Roland Salmon is the former director of Communicable Disease Surveillance Centre based in Wales. Dr. Ros Jones is a retired paediatrician who's had extensive involvement in trial developments, and Dr. Dave Cartland, who's a recently retired GP and published author. It's a real pleasure to have you with us today to address this important subject. I'd like to take the opportunity just to learn a little bit more about each of our panelists today and why you believe this issue is important. Ros, you've been on the podcast with us previously. Would you like to lead us off and tell us a little bit about yourself and why this issue is a particular concern to you?
Yes, thank you, Dan, for asking me back. As a retired paediatrician, I did re-sign up with the GMC, thinking I might have to go back to work if the children's wards were overwhelmed and my colleagues were off sick, etc. But of course, very early it became apparent that as a blessing is that children are barely affected by COVID-19. They catch SARS-CoV-2 infection and they get often no symptoms or trivial symptoms, and their chance of serious illness is remote. So in fact, the children's ward at my local hospital was eerily empty in the first wave, often with parents afraid to bring children for conditions like diabetic coma, even, really worrying lack of children coming to hospital. So then I started campaigning really when I saw the schools closed and then not reopening, which seemed an odd thing, close them for a few weeks while we worked out what was going on. But I think I had anticipated schools going back in, half-term Easter holiday of 2020, and they just didn't. So that's when I first started getting involved. Then I joined HART, the HART group, in January 2021 when they were just founding. And we've been looking extensively at children's vaccines. I was very concerned to see Andrew Pollard advertising on television the children's AstraZeneca trial. And I wrote to him straight away saying, I'm really surprised you're doing this when you haven't yet got the adult long-term safety data, well, even the short-term safety data. And he actually agreed with me and said, we don't know it's safe, that's why we're doing the study, which was a little disconcerting, I have to say. And I've carried on with this ever since.
Thank you, Ross, for sharing that. And Dr. Roland Salmon, I understand, the Chief Medical Officer was the one that was responsible for approving the vaccinations. I understand your path has crossed with Mr. Whitty. Tell us a little bit about your background and your reason for taking interest in this subject.
Yes, well, I'm a medical doctor and also a field epidemiologist. And after working in hospital and general practice, I trained in public health, and from 1990 onwards worked for the Communicable Disease Surveillance Centre in Wales, becoming the director in 1998 until I retired at the age of 60 in 2013. So I was actively involved in the surveillance of a number of infectious diseases and in helping health authorities and local authorities manage outbreaks. I also happened for a couple of years to chair the Department of Health's Advisory Committee on Dangerous Pathogens as acting chairman, to be taken over by one Dr. Whitty, who had a brief exposure to that before becoming Chief Scientific Officer at the Department of Health. Another of my claims to fame, I guess, is that I once had to give a flu lecture here in Wales for Jonathan Van Tam when sadly he was taken ill. So I know a lot of the people who've been involved in this, and it's a field I've been involved in all my career. And hence my astonishment, really, which goes back to April 2020, with the aggressive pursuit of lockdown policies here in the United Kingdom. We were being told that this was an unprecedented situation, but anybody with even a relatively short-term memory would have known that in 1968-69 winter, there were 80,000 deaths due to a newly arriving flu variant, and that's almost disappeared from the record. When I was still working in general practice in 1989, I was actually doing a locum during the arrival of the H3N2 flu, which that winter led to 26,000 deaths. So these phenomena have been anticipated. I've been part of committees that were looking at these sorts of things for the National Risk Register. And there were plans, but apparently the plans were never consulted, and the materials that were necessary to make the plans work, such as personal protective equipment, were not available. Instead, we got these very aggressive lockdowns, really with a very, very flimsy evidence base, and for which I've never been convinced that they've substantially stopped the spread of the virus. And they've certainly brought with them an awful lot of collateral damage. So armed with the knowledge that the cure has proved worse than the disease, like Ros, I responded to an invitation to join HART in the spring of last year, and I've remained active ever since. My involvement with the vaccine side of things has come on the back of that. But again, it does seem to me that we're not paying sufficient attention to the needs and concerns of children and young people for benefits that may well not exist.
Thank you, Roland. And Dr. Dave Cartland, tell us a little bit about yourself and your interest in this particular subject.
Good morning, Dan. Thanks for having me. I think my role is slightly different in that I'm a primary care doctor, or at least I was until I know you said retired. I've resigned from the NHS since all of this has kind of reached the critical head, really, in my practical and professional experience. And I'm coming at it in two different ways, really. Number one is as a GP, observing on the ground in a couple of arenas. I've experienced things in a primary care setting, and also as an A&E doctor. I do A&E primary care in out of hours and the A&E settings in quite big hospitals. And I've just made quite observations throughout the whole period. I would add to that I'm also, I've done a previous degree, and that's how that would differentiate me slightly from the general kind of bog standard doctor that's in practice at the moment, in that, a year and a half of that was around immunology, virology, medical statistics, having conversations with fellow professionals has been fairly difficult at the best of times, really, about discussing observations from peer-reviewed journals. The debate hasn't been there. And the final thing I would say, really, is I'm coming at it from a father's perspective. I've got children. I've got 4 children, 3 of which are on the crosshairs of the government, in that I've got a 5-year-old. Obviously, if we were in Wales, we'd be having a different discussion now. I've got a 10-year-old and a 13-year-old also. So, as a protective father and a doctor, I've made observations throughout this whole time. And just to back up what Ros was saying, really, in her introduction, that I've seen the quietness, I've observed the quietness of, particularly around, well, healthy adults. I don't think I've seen a child in the whole pandemic. That's, in fact, I've seen a lot less just normal winter bugs, to be honest, the last couple of years when I've thought about it. And so that's my experience that I'm sharing, hopefully, as I go on and do these interviews, really, of what I've seen, what I've heard. And as you've heard, I've resigned because of what I've seen and heard. And that's why I'm asking people to kind of wonder why I've come to that decision. What have I seen? What have I heard, witnessed? And what have I not been able to share through the correct channels?
Well, I think that's certainly going to have to be something that we involve in our discussion today. We launched the Pandemic Podcast really to ask the questions that most seemed unwilling to ask. These are important issues, but they've become almost taboo, and they've been politicized. But it's such an important issue. This is children's health, their safety, their well-being that's at stake here. And I think we all have a shared desire to look out for our children. I'll go to Dr. Roland. Salmon. Tell us a little bit, why do you think this has been such a difficult conversation for people to have? The fact that we're having this conversation today is a very important conversation to have. But why is there such reluctance to be able to address this issue, do you think?
I think there's been a general reluctance to engage in debate that perhaps stems from a number of things. Our experience of this pandemic has been rather different in a couple of ways. One is we understand with a great deal more precision than we ever did in the past, what the viruses are like and where they are. And I think we've had trouble or assimilating that information. The other thing, there's been a profound impact, I think, of social media. So we've actually seen up close people's experience of the disease. And I think that has, in some ways, distorted our response. I was very struck listening to the Chief Medical Officer for Wales talk at a BMA meeting that I went to, when just sort of apropos of nothing, he said, well, if you'd seen the social media pictures from Italy, you'd have realized that we couldn't have done nothing at all. Now, I'm the last person to suggest that we should have done nothing at all, but it does seem to me, once those sort of things become the main drivers of your response, and once those sort of things become politicized, then what I can only describe as more rational scientific debate that tries to quantify the risks and benefits for all age groups becomes much more difficult. We knew early on, both from the data from Wuhan and from the Open Safely study based around Oxford and London, that the biggest driver of risk was age. With every decade of age, your risk went up 5 to 10-fold. Yet we seem singularly to have failed to internalize that in our public policy, to the point where actually we put some of our older populations actually at risk by the decisions we've taken.
Now, Ros, I know you've been heavily involved in this issue around children since the very outset. What has been your assessment of the impact of the virus in general upon young people and children? Is there a genuine concern there? What's been the impact of the virus on children and young people?
Well, I think I'd echo what Roland has just said. I think the problem is that people have seen a lot of pictures and fearing about the impact that doesn't take age into account. There was something very recent. The NHS was saying 1 in 100 children are being admitted to hospital with Omicron. So it might be safer for everybody else, but it's worse for children. But that isn't correct. And they've actually had to take it down because they were saying 1 in 100 of hospital admissions, but the hospital admissions are clearly, that'll just reflect what's going on in the population. So if at the time 10% of kids in the school had tested positive for COVID, then any of them who went to hospital with a broken leg, car accident, surgery, appendicitis, whatever, they were all being tested. And then you would expect 10% of them to come up with a positive PCR test. That's exactly what was happening. And at the same time, so the number who were genuinely ill with COVID was completely wrong. And at the same time, the denominator was wrong because it didn't take account of the fact that lots and lots of children who got COVID were not even getting onto the data, because you wouldn't test a 2-year-old with a snuffle. Well, I hope you wouldn't, because I think that would be quite cruel. And so they would never get into any statistic at all. And the other thing which hasn't come out, which is that of the children who have been admitted to hospital and where there have been deaths, we've known this from very early on, that there are some comorbidities, and the same goes for adults. It's not just age, it's also comorbidities. So the children who've got serious comorbidities, then for them, vaccination has possibly been very reasonable. But that's not at all the same thing as saying you should roll it out to healthy children who are at minimal risk, probably 1 in a million chance for a healthy child to die of COVID. And that was last year with Delta. And now with Omicron, that risk has gone even lower.
Yeah, I was just going to add, Ros, that the recent statistic that's just come out from the Freedom of Information Act about the average age of people that have died of COVID, or within 28 days, I should say. It's above the average lifespan, which is bizarre, really. It adds years to your life getting COVID, apparently. So it's really bizarre. And just to echo on what you were saying about, we as doctors starting off in this pandemic, we've all been gripped by the same statistics that are being, I'm going to use the word peddled, because, I can't quote a table or government data set without the referencing, whereas the government seem to be able to just put out a statistic. I heard one this morning on Spotify that just said, if you're pregnant, for example, get your Omicron booster because it's the best way of reducing your chance of death by 8 times. And there wasn't a reference or anything, when these politicians are speaking, there isn't any scientific reference into the data set that they're quoting, and they seem to have license to say whatever they wish. And just going back to the point about, going through the pandemic early on, we're all subject to that stuff. The reason I took 2 jabs, that's what my unique position is. I have been vaccinated. I've had 2 jabs for different reasons. But, you know, some of it was fear, some of it was believing what Chris Whitty was telling us. You know, Van Tam was saying on the slide sets, the daily bulletins, the one-way narrative that we've all been subject to. So it's completely understandable that, you know, people are hook, line and sinker for what they're hearing, really.
Well, I think that makes an important point. I'd like to address this to Dr. Salmon in terms of, because we can talk about, you know, I'm not a medical professional, but here we're joined by 3 medical professionals to talk about the science and the data. But for the parents at home who have got children, and they're obviously deeply concerned about their children's well-being, they've seen, we've been bombarded for 2 years now of all of the horror stories and this very emotive picture. So I tried to understand how these parents are, you know, I'm a new father myself, and the concerns the parents may have based upon obviously the information they're consuming. They don't have the background to be able to assess that information and to critique it. So, you know, for a concerned family parent who's worried about their children, how do they make sense of this? Because they still appear to be afraid to allow their children to get COVID-19. And I think there's an important component here that is around natural immunity and the role that plays. So Dr. Salmon, do you have an understanding of what kind of proportion of young people have been exposed to the virus and therefore garnered immunity naturally?
I mean, I think Ross may be better placed to answer that than me, but I understand we're looking at around 80% of the pediatric population. So the amount of immunity out there is high. And of course, that immunity very effectively reduces transmission and is actually protecting vulnerable people probably rather more effectively than vaccinating children would do, which is rather ironic. I think you make a very good point when you refer to how are parents supposed to make decisions? I mean, traditionally, we have had very successful immunization programs in this country since really the whooping cough vaccination debacle in the early 1970s, which was shown to be pretty much entirely without, well, not pretty much, entirely without foundation. And why has that been the case? The basis of the vaccination campaign has been scientifically driven from the Joint Committee on Vaccination and Immunization. It's had coherent central organization from the health departments. It's had effective local delivery. And it's also it's made sure that health professionals delivering locally understand the logic with the Green Book, the handbook for immunization against infectious diseases, and the uptake's been carefully monitored. The whole debacle around trying to promote COVID vaccination to children to do things that it's actually not going to do threatens, it seems to me, to undermine that much more widely and to give us a great deal more problems with maintaining public confidence in the other antigens that are available, all of which I would see as essentially very necessary.
Ros, would you like to comment on that? I think there's been some misconceptions about the nature of the vaccine itself. I know, speaking to other parents, many don't understand the distinction between a traditional vaccine and the new forms of vaccine, the mRNA vaccines, but also in the notion of the effectiveness and what the vaccine does and does not do. Would you be able to comment on some of those misconceptions about the nature of the vaccine?
Yes, I absolutely. I mean, I think one thing is the downplaying of natural immunity, which Roland just referred to. Early in the pandemic, when people had got COVID and they were recovering, people were saying, oh, but their antibodies will wane. Well, antibodies always wane because you don't make antibodies every day to every disease you've ever had. Your blood would turn to sort of porridge if you did that. What you do is you make loads at the time and then they just decay under the natural decay of immunoglobulin. And then if you meet it again, you've got those memory cells which immediately produce antibodies. And we've got very fixated on antibodies. So if you give a booster, you can see the antibody levels go up. But that doesn't necessarily mean that that booster has made you more protected from against catching the disease. You might have had some good protection from your previous dose, but you'll soon see the booster giving you more antibodies. And so the suggestion is that even if you've had the infection, you still need to be immunized as well. There's no evidence for that. Interesting that both Norway and Holland have recently come out clearly saying that children who've had COVID don't need to be immunized. They're not eligible for immunization. And we could have perfectly well done the same here. And we've got, most secondary school children will have known that they've had it because they were doing endless testing in schools. And maybe some of the primary ones won't know, but if they wanted to, they could easily be offered a test like the lateral flow test, but just you could do a saliva test for antibodies and say, oh yes, you've got antibodies, you don't need to be immunised. But we haven't done that. And Chris Whitty was asked, in fact, about that and said it would be much too complicated. But we always did that for the TB vaccination. We had to have a MAN2 test first to decide whether children had already been exposed. And you didn't get a BCG if you'd already had an exposure. And if you did, it went extremely manky and you overreacted and it was horrible. And I think we've got the same here, that we're putting children at risk if we add a vaccine to an existing immunity that they just don't need.
Dave,
in terms of what the information that parents are getting, it's as vague as what we as adults, when we receive the vaccine, are getting. I would say that when people are rolling up their sleeve, they're not particularly being very well educated, and I would challenge any vaccinator. I've done the course myself. A disclaimer: I've not actually injected any person at all, but the information gets very basic. And so people are obviously trusting their doctors, trusting their vaccinators. They're getting their information from vague kind of government, headlines, and the vagaries go all the way to the top of the chain, really. So it's impossible to impart that trust as parents to your doctor when your doctor actually doesn't know. Some of the vaccinators don't even know it's mRNA. They're not aware that it's kind of in a clinical phase 3 part of the trial. The safety data is lacking, etc., etc. So that's where the lack of trust comes from, and that's why it's difficult to reassure parents.
Yes, I think from this discussion, from the very least, it seems futile to vaccinate or immunize someone who's already been exposed to the virus, but particularly with reference to children. We've been talking about the underlying risks of the virus here to kind of contextualize need, because I think the conversation about the vaccine is typically driven by risk and benefit analysis, or at least that's in part what we've been witnessing. But to conclude that, those who have been exposed to the virus may not need it. What about the remainder of the children? Is there a fundamental need nonetheless for children to be vaccinated? Dr. Salmon, what's your take?
No, I don't think so. I mean, I think what we have to bear in mind here is that the profile of symptoms that you get is similar to a lot of other upper respiratory viruses that normally circulate among children. Now, we might arrive at some happy utopia in the distant future where this is no longer the case, and then that would be appropriate. But for the time being, in as much as SARS-CoV-2 doesn't seem to be causing disease that's very different from another of other respiratory viruses in children, we shouldn't be singling it out for special treatment. And by doing so, we distort people's perceptions of risk. And by doing so, that very trust that I agree with Dave is a key element in doctors looking after patients, threatens to be undermined.
Yes, I was interested in the reply that because you've written another letter, haven't you? You signed the letter with a group of MPs and House of Lords. And you had a reply from the JCVI initially to the first letter. But I think one of the things, if I'm right, was that they were saying, well, even if there wasn't a requirement to vaccinate children against Omicron, which is so vanishingly mild, there might be a more severe variant in the future. So you're like guessing, they're second guessing whether these children might need a vaccine against a new condition. And that doesn't seem to me reasonable. And I think this is part of what our campaign is about. It's asking to re-look at the balance of risk and benefit. So when the JCVI back last September were initially saying they didn't think it was an appropriate vaccine for 12 to 15s, let alone 5 to 11s, they looked and they said the benefit in terms of health to children was so marginal that it was not appropriate for a routine rollout. And then they got ineffectively overruled by the chief medical officers. And this went ahead on the basis of trying to keep schools open. But I think if you were to look now at the risk benefit, the risk from Delta, which is what was around, or not even, it wasn't even Delta, it was a lot of Alpha and so on, that they were basing their decisions on. Obviously that risk was higher. The risk from Omicron now for adults and children is about a fifth of what it was. So first off, their marginal benefit to children by keeping them healthy and out of hospital has gone right down. And secondly, on the risk side, there are still a lot of risks that haven't been fully investigated. And if you look at the JCVI minutes back from last August, they were very anxious about myocarditis in children. They talked to the people in the States who'd done MRI scans and shown quite significant scarring in children who'd had quite short-lived symptoms and seemed, as we keep being told, oh, this is fine, they just get better in a day or two. But when they scanned them, there were really significant changes. And they are doing a follow-up, sort of 3-month on for all these kids. But we don't have that data yet. And the JCVI actually wanted to wait, but they said probably up to 6 months to get all the data in before they made a decision. Now, that seems to me a very sensible way of looking at it, because why would you rush when children aren't at particular risk to give a vaccine where you don't yet know the safety data? And since then, a lot more has come in. So for example, Hong Kong have looked prospectively, really systematically, as they rolled out their 12 to 17s program. And they've come up with a risk of myocarditis for the boys after their second dose of Pfizer at 1 in 2,500. And on the basis of that, they've actually stopped the second jab. They said they would follow the UK system of only giving 1 jab to adolescents. But meanwhile here, suddenly, with no additional data whatsoever, the JCVI, who'd originally said only give 1 dose because they were aware of the increased risk with Pfizer with each successive dose, they then suddenly said, oh, well, why don't we give 2 doses? So we are going to, I'm sure, see more signal of teenagers getting myocarditis, inevitably, because we're now rolling out the second dose. And that's where this question about the increased all-cause deaths in teenage boys that's been exercising a lot of people. And we've been to court to try and get ONS to say, and they have acknowledged that there is a statistically significant increase in deaths, or non-COVID deaths these are, in boys aged 15 to 19. It doesn't occur for the girls, and it doesn't occur if you look at 10 to 14s or, the younger age groups. And we're not saying that the vaccine rollout, because this increase coincides with the start of the vaccine rollout, and we're certainly not saying that the vaccines are causing this, but we are saying they should investigate. Because if the vaccines are causing it, then we need to know and stop. And if the vaccines aren't causing it, that would be very reassuring for the programme. But also we do need, surely as public health, to know what is causing it. Is it increased suicides, or who knows? We need to know. And yet they still won't investigate, and they won't give us the data so that we can.
Now, I think there's a good point here. I mean, it's a key tenet of communicable disease surveillance that you do it in order to detect abnormal signals. And if you detect abnormal signals, you hopefully are in a position to follow that up with some sort of field investigation where you actually go to the cases involved and find out some detail about what happened. And it seems to me entirely reasonable to do that with the excess deaths that have been observed here. Personally, I always somewhat wary about reading too much into these sorts of changes in the short term, but I certainly think they should be looked at. I also would perhaps just mention the question that has arisen of the JCVI's original decision not to vaccinate 16 and 7, not to offer vaccination to 12 to 16-year-olds, that was effectively overruled by the chief medical officers. I mean, I think by and large, the JCVI have made some very sensible decisions through this pandemic, and indeed some quite difficult ones, like, for example, their initial decision to give a single dose of vaccination to as many people as possible before they gave the second dose. And I think that probably did protect a rather large number of people. There'll be others that disagree, but I think the data bears that out. So it's very worrying when they've made a scientific recommendation on the basis of the public health, and they find themselves overruled by the chief medical officers in effect, who, as far as I can see, have exactly the same remit as the JCVI do. This all sort of smacked of a rhetorical device dreamed up by the civil servants in order to support their ministers to allow a different decision to be made without the political responsibility for that decision being taken by the politicians. And I'm afraid that the chief medical officers, in going along with it, haven't done anything at all for either the independence and integrity either of themselves or of their office.
I would just add to that, Roland, that the whole word harm, vaccine harm, it's the big elephant in the room that nobody really wants to talk about. that's from one-to-one towards other colleagues, or locally or nationally, or any of the epidemiological stuff. Locally to my surgery, we just, I'm noticing little spikes in things like blood clots, in the adult population, cancer diagnoses, right through to observations in children, like the myocarditis stuff that's, even around our little hospital in Cornwall, and there's no collation of that data. There's no sort of acknowledgement that, there is a possibility that, the jab was given yesterday, the child's got myocarditis 2 days after presenting to accident and emergency with a raised troponin, which is the enzyme, as just explained to Dan, that is high if you've got an inflamed heart. And that link to the fact that it could possibly have been to do with the vaccine is just not heard. It's dismissed almost. And I mean, we've written letters, haven't we, Ros, as part of HEART, and they fall on deaf ears. We've written them to the right people with the right statistics, fully referenced. We didn't get a response, did we, for the first one? I know we've written a recent one to kind of...
We've written, I think we're on our 6th letter now. It's been very depressing. Interestingly, one group I have had a decent response from was after the 5th letter, it's still not had any satisfactory replies. These are letters to the MHRA mostly, and some to the JCVI. But I wrote to the GMC and sent all our letters to them. And they wrote back and they said some of these questions are not within our remit, but they particularly picked up on what I was concerned about, which was informed consent. Because this mantra, safe and effective, is just being given the same to everybody. And obviously the advice you give when you're talking to a 17-year-old is completely different from talking to a 70-year-old. Because the risk of COVID is way, way down, and the risk of the vaccines is perversely higher the younger you are, probably because they're mostly mediated through the immune system. So you get more myocarditis. The 16 to 17-year-olds are the highest group for myocarditis in all the international studies, more than, say, over 20s, let alone over 30s.
It's really
easy. We agreed that we were not getting proper informed consent, and that actually it's really important.
I was just saying that it's really easy to sort of disperse. I've seen footage of local, protesters going to the vaccine centres, for example, and campaigning and just asking simply for data, simply for the reassurance that every parent, every patient wishes to see. Very, very easy it would be to get rid of these people in one foul swoop. Give them the data. Very simple, give them the data. If it's safe and there's effective studies, give it to them. They'd be off. And we're not seeing those exchanges happen because they don't know and they haven't got the data is the answer. But
Can I ask a question, Dan, of Dave, because he's been working in general practice recently. I mean, I'm assuming that he's diligently been submitting his yellow cards to the MHRA, but what's his experience of his the extent or otherwise that his colleagues may be doing that?
I mean, the way general practice is at the moment is if you have your sandwich, you're lucky, let alone fill in, these yellow card forms. I mean, you do as much as you can, but, a lot of doctors haven't got time, haven't got, they don't know about it, some of them, the yellow card, the green, but, there's not enough hours in the day these days. So, yeah, I would probably, this is speculative, would say that the vast majority, and we've seen that in the sort of estimates of under-reporting under the yellow card system, and the estimates from MHRA as well, that these things aren't being reported in the numbers that, by some order of factors, I think the estimates I last read were sort of 15 to 20 times under reporting factor. So any sort of statistics, a bit like the deaths on the yellow card system's currently sat at around 2,000. If that's being underreported by, let's be conservative and say a factor of 10, that's 20,000 deaths in the adult population. We don't know in kids because those data sets aren't there.
Yeah.
I think
as vaccinating.
That with the podcast, we've had a lot of inbound anecdotal stories around this, which of course, is not scientific in its approach, but it is of course for signal. And many people have told us that they've had incidences within 7 to 10 days of their vaccination, and it's not even a case of not reporting by the yellow card. There seems to be a dismissal that there's any causal link. We had a whistleblower from, and he's refused to go public, but he's a consultant. He's been fully vaccinated himself, but he dealt with this was prior to the AstraZeneca issues that were made public. He dealt with 8 women in the same evening of 30 to 40 years old who had blood clot issues in close proximity to the vaccines. He assessed them for the usual kind of markers that would lead to clotting. and none of them had met that description. So his alarm bells rang. But when he discussed it with other colleagues, people were suggestive that there's no evidence yet that there's a causal link. Therefore, they can't report this as an issue that could be correlated with the vaccines. And that for me was a very damning alarm bell. That on one hand, you've got people.
There's many people like that, Dan, to be honest. I mean, I've been contacted since my resignation now that there's been a lot of doctors coming to me and say, oh, it's brilliant what you're doing, stepping out, you've resigned because of what you've seen. But there's a general fear now amongst colleagues to speak out. Exactly, that guy's seen 8 patients that one evening, and then you go to your colleagues to express that concern, that signal of harm that you've seen, and it's dismissed. People have walked out on me when I've just presented the myocarditis data to them, and these are people who've got interests in, paediatric areas, really safeguarding doctors that are not interested seemingly in child safeguarding. And people walk out, people are quite visceral in their response to you in terms of you have these conversations, they'll walk out, you're disturbing their coffee break. And it's absurd. I haven't got my head around that mentality among fellow professionals, really.
Well, this is what contributed to this situation where we just don't have the transparency. And, when it's such a serious issue, I mean, we've talked about the underlying risks of COVID, where we have a lot more insight and data. And, there's a general consensus amongst this group that and many others that the risks for children and young people are significantly lower. That's acknowledged by most. But when it comes to the vaccines and the benefits and the risks, there is not that volume of data that is publicly accessible. In fact, Ros, you've mentioned that you've tried to go to court to try and get this evidence, and to me this becomes a very, very muddy area, because there's the informed consent at the parental level. How can that be possible if the medical professionals themselves don't have access to the reliable data? You've spoken about some of the signals that we've seen in terms of vaccine injuries. We've touched upon some of the anecdotal elements where people have had issues. How do we move forward from here? And because if we're not tracking, if there's no tracking for the short-term problems, how can we have confidence that the long-term issues are being tracked? Is there any evidence that that's happening? And what can we do to get that clarity? Because to me, that's 101. We need absolute transparency around this.
Yeah, no, I absolutely agree. I mean, I think the College of Pediatrics, they were very good all through the first year, putting out lots of information for parents that was very reassuring, and how mild this was, and talking a little bit about the rare complications that can occur and how to look out for it early, so that, your child would get a good treatment and make a full recovery. So they were very clear on that. And they were not pushing, I don't think, for the vaccines at all. But once they were approved and authorized, then they immediately just went behind the government and said, oh, well, no, good idea, sort of thing. And what they haven't used is there is actually a pediatric surveillance system, which there's a card which all the consultant pediatricians in the country fill out every month with rare conditions on it. And it would have been really easy to have just put myocarditis on that. And then you just tick a box, send it back on a free post, and then the researcher gets in touch with you and finds out a bit more detail. And that they could have very easily done that. Perhaps I should be contacting them to say, it's certainly, if it goes out to a second dose to 12 to 15s, they should be doing that right
This
now.
causal effect of vaccines, though, Ross, is the issue. People literally will not think about the vaccine being the cause of a heart attack.
I know, but if you've put all myocarditis, that's what I'm saying, put all cases of myocarditis on your card.
Okay, I'm with you.
Because you see, people are saying, oh, well, COVID has caused more myocarditis than vaccines, but that's not really right. The big Oxford study, if you looked for the over 40s, it seemed that the disease caused more trouble than the vaccine. But for the under 40s, it was the reverse. And if you went to under 20s, which they didn't, because they only had these two under and over 40, you would find that would swing even further towards saying that the vaccines are more hazardous than COVID. And I think this is the problem, isn't it? How we get people to, interestingly, Japan have now made it absolutely mandatory for their doctors to report any illness that occurs within a week, I think, of the vaccine has to be reported.
But this is the thing, Ros, all throughout the pandemic, and it's easy for me to sit here as it should have been done this way or that way, but there's never been that kind of consistency nationally, internationally, an approach top down. This is how you do it. This is how you audit things. This is how you record the adverse effects, the clots, etc., etc. And it's just been organised chaos, really, from seeing it as a professional. I've not had that kind of leadership throughout all of this in terms of this is what we should be doing about X, Y, and Z. It's not been, 1 minute we were eating out to help out, the next minute we're being locked down, the next minute we're in groups of 5, then 2, then we're out in parties. And it's just been that sort of thing. It's inconsistent. And the public are seeing that from the outside looking in, thinking, wow, can they get there? I mean, even within our own country, Wales have rolled out yesterday, didn't they? They've announced that 5 to 11s are in the crosshairs next. But other parts of the country aren't. The mandate was, it was England, but not in, Scotland and Wales. There's not. And people are seeing that, thinking, what are they doing here? They've got to trust us in this. And this is going to have repercussions on the future after all of this, on the programme of vaccination. Aside from COVID, people are going to say, look, these guys have been blindly vaccinated without the facts, without the safety being acknowledged. Are they going to trust them in the future for things like the MMR, the childhood vaccination programme? The trust has gone or going.
Well, this is my fear, certainly, that the rather disjointed way this has been approached with a large dollop of politics and different approaches within the 4 UK countries is going to undermine efforts in what was essentially an immunisation programme up to fairly recently organised in just the way that you would have liked to have seen, Dave, as I say, with central direction and with clear reference sources that people could use. I must agree with Ross. I think the British Paediatric Surveillance Unit system of studying rare diseases would work actually quite well for picking up some of the potential signals from vaccine here. And after all, they identified aspirin as a cause of Ray's disease back in the late 1980s, early 1990s.
And it's gone. We just don't see it anymore. It's amazing.
And what I think I would also say, though, is I've investigated a few clusters down the years, and they turn out to be pretty evanescent when you look at them. So that my colleagues don't leap at the opportunity to investigate what seem like clusters of vaccine-associated illness, as that's not their approach, I'd perhaps forgive them a bit. But what I do think is necessary, and what is the answer to most of these problems, are sufficiently large and systematic studies that follow people up from the date of vaccination, or potentially use record linkage to virtually follow people up from the day of vaccination. And I think until we've got that kind of information and we either find it's reassuring or it's not, these questions will remain.
We've seen a model of that in the Hong Kong data, as Ross referenced earlier, that robust prospective data that can't be messed with, really, but it's gold standard data, really, and we need to, have we got anything similar in the UK? I fear not.
Yeah, I mean, the simplest thing would be to actually physically give a yellow card to, they used to be yellow and they were in the little formulary. There was a serrated, you could tear out these pages to fill in if you saw an adverse reaction. Now it's mostly online, but you could give the parents or the, anybody, adults having a vaccine, the card, and it could have a tick box of likely side effects and a place for other, and, just please return it prepaid after 30 days. In a month's time, send this back. And as you say, you couldn't perhaps do that across the entire country because the numbers coming in to the MHRA would drown them. But you could certainly have done that quite easily in an area. Say, okay, all the children who are going to be vaccinated in Buckinghamshire, please, you'll be given a card.
It's not label intensive, is it? It's really commonsensical stuff.
Yeah, I mean, a cohort analysis would be quite a simple way to get some clear signal. Now, so obviously we've talked about some of the underlying risks of COVID and the potential lack of need to vaccinate children. We've talked about some of the benefits and the risks and the misconceptions around these areas, and fundamentally come to a conclusion that there's a real lack of transparency. And I know, Ros, you've been campaigning hard to bring that forward, and now you have a new campaign. I think it's important that we talk about some of the things that can be done to address this, because I know, as this vaccine now being rolled out in Wales for 5 to 11-year-olds, potentially wider, speculated that there's going to be a press conference on Monday. What can be done now? What are you doing at present in order to try and drive awareness of this issue?
Well, we are launching a campaign later today, and one of the things we're doing is we've got a sign-up page for health professionals for the letter that we wrote, that the three of us have signed. We sent it to the JCVI with just over 90 signatures, which are all people that I've been in touch with over the last year, and they've sent it to colleagues, etc. So it's been a personal networking. But this is going to go out hopefully to the general public to say, please contact your GP, give them a copy of this letter, ask them if they'd be prepared to sign it. And there's a click type sign on that you can then put, and verified by email, you put your name and qualifications. And I would really be pleased if we could see a sudden build-up in the number of health professionals who were prepared to put their name to this, because I think that might make the JCVI think, and the politicians perhaps think more, that, there it is. Yes, that's it.
So this letter then, we'll put the links to this letter in the episode, but, you explain a lot of what we've discussed here today, but as you can see, co-signed by lots of different doctors and professors, medical professionals. What do you think, what's your aim with this? I mean, who's this directed at, and what do you hope will happen as a result of this letter by having so many doctors sign this document?
Yes, I think what we're hoping is that whereas when we've sent letters with 60 or 80 or 100 professionals, we don't get a sensible answer, that if we can really amplify this and get, several thousand doctors on this letter and other health professionals, then what we would aim to do is actually a group of us would go to the JCVI offices with a large bundle of pages and actually present it to them with perhaps some press coverage. That might raise awareness. I think the public, we want to raise awareness with the public as well, because at the end of the day, if we can't alter the view of the JCVI, it is still up to parents. And if you look at the uptake for the 12 to 15s, it's only around 50%. So half of parents have already probably thought, I don't think my child needs this. So if we can raise the awareness, particularly of that there's no need to get your child vaccinated if they've already had COVID recently, and particularly given that the current vaccine is the vaccine to the original strain, the Wuhan strain. So it's got very poor efficacy against the current strains anyway. So what's the added benefit? So I think it's a dual campaign. One is to possibly shift the view of the JCVI, but I think that's vanishingly unlikely. But at least in doing so, to raise awareness of the public and parents to say, you don't need to get this vaccine for your children, whatever the advice you're being given by the official narrative, just take another look.
I think that's a really key thing.
I don't agree.
These parents can vote with their feet, can't they? And I'm seeing that a lot in the local and national media, on social media, for example, and where previously an advert would go out and say, come and get your child's second jab between these ages. The comment section is very different to the comment section 2 or 3 weeks ago, where people are literally waking up to this now and questioning these things away from the media narrative. So there is an awakening happening.
And one thing that was raised in the JCVI, it was interesting, there was an article in the paper a couple of days ago about the fact it's been pushed back from last Friday, the announcement, and then till this Monday and now to next Monday. But they interviewed somebody from the JCVI who said that they were doing this to appease parents clamouring for a choice. And there's been a lot about parents clamouring for foreign travel, because in the UK, there is no requirement for this at all. So your children are not being, stigmatised or in any way affected adversely by not being vaccinated. But you can't easily travel to your skiing trip in France. And yet you can, because 12 to 17s can go on their adult parents' vaccination. And anyway, would you really put your child's health at risk for the sake of a holiday? You can cancel the holiday and go next year, because you look at what's going on around the world. All these mandates are coming down all over the place. There's, there are hundreds of countries, over 100 countries you can visit with unvaccinated children, and will welcome you with open arms. Just don't do it for the sake of a holiday.
I mean, it's not just holidays, Ros, is it? It's holidays. I've heard comments coming out of the vaccination room, witnessed with my own ears, that, kids are just, you cry if you heard some of the reasons they're coming out saying, I can play with my friends again. I can go and join my football team again. Younger adults saying, I can go out to the pub again. It's the freedoms that they had before.
Yes, but all those freedoms are actually fully available to them. So if they think they can't go, they're being really fed a fear message that is wrong. The idea of a parent saying, oh, now I can have them round for a play date. They always could. Apart from that we've had 2 short periods of total lockdown. But apart from those, there's been no time when you couldn't meet your friends and go for a play date. It's ludicrous.
Well, people don't know the rules, to do any of this. We've lost track of the rules. I mean, even as medical professionals, I don't know the isolation rules or anything now, because it changes week by week. So how are parents and normal punters going to follow the rules? It's impossible.
No, I think that's a very, very pertinent point. I mean, it seems to me there's been two drivers here. One is for, broadly speaking, working parents who sort of felt this would prevent illness in their children, would make the organization of their lives much easier. And that was important to them because there was probably economic drivers at work here. And I think the other thing has been perhaps some of the trade unions in the education sector who've been worried about the health and well-being of some of their more vulnerable members. Now, I happen to think that's an entirely legitimate concern, but actually vaccination of children is not the way to address it, because it won't do anything to make that situation better. The way to address that is for modifications on the redeployment, sickness absence and retirement rules that could make sure that those people who work in the education sector who are vulnerable are kept away from vulnerable situations. I don't think there is a lot or that's extensive, but I do recognize that as something that if I was a union official or a union member, I would want to see addressed. Yes. But vaccination is not the way to do it.
Yeah.
Well, Roland, on that point, I think we've seen that kind of shift in emphasis where, traditionally we'd see the adults being responsible for protecting children, but that mentality was, I do agree with you, for the adults who are at risk, there is obviously a tangible reason for them to be concerned, but there are obviously steps that they can take to protect their own health, including
vaccination, of course.
They can get vaccinated if they choose to. But now we're seeing this emphasis of the children protecting the adults almost with this idea. That's some of the stories we've seen in the media come across that it's about protecting the community and about protecting its onward transmission. And I think all of these things have kind of etched in people's minds. And it goes into what Dave and Walter were discussing around the need to get vaccinated. It's not necessarily been driven by medical reasons. It's been driven by lifestyle reasons, which is one flaw. And then the other flaw is that this idea that the children have a responsibility to protect adults. And this is deeply contradictory to our, in my view, previous approach to public health. What's your take on that, Roland?
I would say it's by and large contradictory. I mean, for the most part, vaccinations are given to children because they protect the child. That's the beginning and the end of it. There's one notable exception to that, which was the introduction of nasal flu vaccination. I can't quite exactly remember even to which age groups because it postdated my retirement. But even then, there is some individual benefit to the child involved, as well as the effort that's done to prevent circulation among school staff, parents, that sort of thing. The problem that I have with the coronavirus vaccination is I don't see direct benefit to the child who's receiving it. So you really are just therefore giving it, if you're giving it at all, to protect other people. And that does seem to me to be a novel and I don't think justifiable departure.
And the other thing, of course, is that, as you already mentioned, it's not going to work, because one of the perverse things about Omicron is that the current vaccines are not really effective against it. And if you look at, they may give some benefit in terms of reducing serious illness and death. But that's not going to apply to the children. But in terms of preventing you catching it and transmitting it, it's actually from the, Public Health England or UK data is that the number of cases is higher, the rate of cases is higher if you're triply vaccinated than if you're unvaccinated. So by taking this vaccine, you are not in any way going to protect your vulnerable relatives or friends. And there is this thing that's been shown very early on in the Pfizer trial and also in Public Health England data, that there's a slight increase in cases in the first week to 10 days after vaccination, presumably because of something about the effect of this vaccine on your immunity. So actually it gets worse before it gets better. And so if you were wanting as a child to get vaccinated because you had an immune compromised parent or grandparent in your home or sibling, actually you might put them at more risk initially. You really should go and stay somewhere else while you get your vaccine and wait till you're 2 weeks down the line. But nobody's made aware of that at all.
No, that's true. I mean, I've always thought, I have to say, that I thought that increased risk in the first 2 weeks is you got a bit carefree, but yes, it may be, it may well be immunological.
And well, that brings us back, actually, we've talked about the side effects of myocarditis, and I think that's been covered because it's the one that's come most into the public domain. And it has been acknowledged, and it's now on the data little patient information leaflet, and there's a guidance to doctors about, how to treat it and so on. But the one thing that hasn't really been publicly acknowledged is the effect of these vaccines on the immune system. And one of the worries that perhaps for children, particularly the younger they are and the more flexible their immune system should be, that we may in some way get them onto a track where they are only responding to the vaccines and they're not responding to normal infections. And we've seen that with the vaccines, that they're each time the effect wanes and you need to get boosted again. And we don't want to be putting children onto a pattern of frequent vaccinations over years. That may have completely unknown effects on their immunity.
No, I agree with that. And I think, again, there's a precedent, isn't there, in the fact that we don't give varicella vaccination to children, chickenpox vaccination to children, precisely because we don't want to delay the onset of the illness till they're adults when they will get much more severe disease. We prefer that natural immunity was built up in childhood when, for the most part, disease, if uncomfy and a bit, inconvenience, a full recovery is to be expected.
Yeah.
So in conclusion, we've obviously seen the campaign there to drive greater transparency and looking to involve other medical professionals and engage the public. I'd like to just ask each of you personally, what would you like to see happen as we move forward from here? What's your ultimate outcome, and what do you think the best case scenario is? And I'll go around in turn for us to do that. Roland, what would you like to see happen?
I'd like to see the vaccination for under 16s paused while the safety data is properly reviewed and arguably more is collected. And I'd also like to see, going forward, the proper separation of scientific advice from political decision making. So I don't want to see the chief medical officer and the chief scientific advisor flanking the prime minister in future. It seems to me they belong in different rooms. That way, it seems to me the public will be able to see what parts of a decision are scientifically based and what parts of a decision are perfectly legitimately arise out of the politics of the situation. And I think that distinction is an important one that's been substantially lost through much of the COVID pandemic.
Thank you. I'll come to you next, Dave. David, what would you like to see happen?
Just sanity to return to science, really.
There's always that.
The ability to kind of, critically appraise, be evidence-based doctors, and just to put a challenge out really to the doctors, clinicians, the vaccinators themselves, really to just look outside of the main narrative really and question, remember, I keep quoting in other interviews, remember the oath that you took to, make your patient your prime concern, whether they're adult or child. And primum non nocere is an oath that we took to do no harm. And as we've talked about myocarditis and other harms during this interview, there is clearly harm going on as a consequence of the vaccine. So I'd even go so far as to extend Roland's, pause at 16 and below. I think cancel 16 and below. It's not necessary, in my opinion, and other people's opinion. I'll put my neck on the line and say that.
Thank you. And Ros, your closing thoughts and your intent.
Yes, well, I would actually absolutely agree with what both Roland and Dave have said there. I think separation of the decision-making from politics is essential, and an end to all the censorship that's currently happening, which is making rational debate very difficult, as Dave's experienced himself. And then I think at the end of the day, yes, first do no harm, and yes, also go back to the fact that all these decisions have to put the child's best interests first, not anybody else's. And that is under international law and under any normal biological fact. We always put children at the heart of protecting them rather than the other way around.
I think I would also like to go one step further than separating the science and the politics. I'd also like to separate the regulation. I think the regulation is too intrinsically linked to the manufacturing process.
Yes.
And too intrinsically linked with the politics. And I think that creates a very difficult predicament when it comes to the approval. And I can't help but keep going back to what was stated in October 2021 by Kate Bingham, who at the time was the head of the government task force, who said this. She openly said that the program would be about weighing up the risks versus benefit profile for each cohort and the individuals within each group, and at that point said there'll be no vaccinations for the under 18s. It's an adult-only vaccine for over 50s, focusing on healthcare workers and care home workers and the most vulnerable. That was the original intent of the program, which in many ways the JCVI at one point tried to uphold, but as we've discussed here, it became a decision that was undertaken by the chief medical officer and the politics of the situation that changed that direction. So we're here today assessing this information and asking for greater transparency. And I would like to close by inviting the public who have been watching this to share this episode, to share this discussion. We take risks having these conversations, sadly, in the day and age that we live in, because the risk of being censored and being smeared. I mean, hopefully you've garnered from this conversation that, no one here is anti-vaccine. This whole smearing of the conversation. This is an important conversation. Dave shared how he's been vaccinated himself, which in my view is a personal choice, and it should be a private choice. But we're in a situation where people have to say these things to kind of ward off the complications of the conversation. But it's important that we do have these conversations, particularly with reference to the children, for their well-being. And I would like to invite each of you not only to share this episode, but also to join the campaign. And I know there's multiple groups supporting the campaign, but you can go to childrensunion.org/campaign, and you'll see on the screen in a moment where that will take you. You'll see the details of the campaign there on the website. You can read about the campaign to contact the GPs and other healthcare professionals to add their voice to this. It explains the nature of the campaign. You've also seen how the letter that I've shown you today on the screen. In a moment, you'll see that, how you can read that in full. Ros has signed, and all three members of today's conversation has signed. You'll see that full letter. And finally, if you'd like to support the campaign even further, not only sharing the campaign, you can actually take upon the logo and use that in your own social media efforts. You can see the new safety signal, pause kids COVID jabs. You can add that to your social media. All of that information is on the Children's Union link that I've shared with you. It's on the screen there right now, and you can participate in the campaign. I certainly will be supporting the campaign and the efforts, and I hope many of our audience will join this issue as well. So please do share this episode so that at least people can have an awareness of the issues that are at hand that we've discussed at length here today. And if you're inclined to do so, please also join the campaign and share the campaign. It's been my pleasure today to host Dr. Roland Salmon, Dr. Ros Jones, and Dr. Dave Cartland for this important panel discussion around childhood vaccinations. It's a privilege to be able to have this conversation, and I'm pleased to play a part in hopefully bringing at least some level of transparency to the issues that we're facing here through this type of discussion. So I want to thank each of our panelists today. Thank you so much for being here, and thank you to each of our audience who've watched this live and in the replay. And I do hope that you will share this important conversation. Thank you to you all for watching, and we'll be back soon again for another important episode of the Pandemic Podcast to continue the journey of asking the questions that most seem unwilling to ask. So thank you very much, and thank you for tuning in.
Thank you, Dan.
If you haven't already subscribed to our show, you can simply do that by visiting danjgregory.com/pandemic.